Hey everybody, welcome back to the ECG of the day. My name is Reed. Don't forget that you can head down to the description of this video and click on the link to download the PDF of this document so you can follow along and make your own notes. And don't forget to subscribe to the channel and like these videos to help support our growth and try to get people to enjoy watching ECG. So let's start off here with this ECG by looking at the forest, and the trees of the forest are my QRS complexes. So maybe I'll start down in this V1 rhythm strip and see what we have going on. I see that we have a pretty rapid tachycardia here. It's wide complex. If I look at the width of these QRSs, they are greater than, my QRS is greater than 120 milliseconds. And so we have a wide complex tachycardia. So what is our differential for a wide complex tachycardia, right? This could be a ventricular rhythm, like a ventricular tachycardia. We could have in atrial arrhythmia with aberrancy. Aberrancy is a funky word to say some type of aberrant ventricular conduction, right? This could be like a bundle branch block, like a left bundle branch block. It could be a right bundle branch block, aberrancy, right? So we need to kind of tease out maybe what this would be. And so something that I didn't notice kind of at first is that first we want to determine, is there a morphology of this wide complex QRS that would be in line with a left bundle or right bundle branch block? And so we can do that at first. I like to do that. And I see that if I look in V1, I see that I've got this RSR prime, RSR prime. So I have an RSR prime in lead 1, and that's a right bundle branch block morphology. However, we know that there are other ventricular arrhythmias that can contribute. If they arise from somewhere within the left ventricle, they can also have right bundle branch block morphology as well. So let's make sure, is this right bundle branch block type morphology coming from the normal conduction on the AV node? Is there some atrial arrhythmia? And so first thing I want to do is think maybe there's like an AFib. And so I look, and so I'm like, let's look at the atrial activity. Are there P waves before my QRSs? I scan throughout for P waves, and I don't see any P waves. I can see my T waves. I don't see necessarily P waves before my QRSs. I see that there are moments of these pauses, right? And these pauses have QRSs that are the same morphology as the normal QRSs. This is not really a behavior of a ventricular tachycardia. Ventricular tachycardias are very, we would say, especially monomorphic, right? These are all the same QRS morphology. It is very predictable once it gets started, right? It's not very irregular. And if you look at the R to R intervals here, you can see that some of them, like this R to R, is a little bit longer than this next R to R, right? And so we have a little bit of variation in R to R intervals. So that's not very common either, right? You can see it here. You can see this is a pretty narrow one. That's like 11, maybe 10 millimeters. And then we've got others that are closer to like 12, right? There's subtle variations in the R to R intervals here. And then we have these nice pauses that really tell us what do we think is going on. And so we've got an irregular rhythm, right, with a rapid rate, with a right bundle branch block morphology. And so in the absence of P waves and any predictable pattern to our irregularity, I would say this is an irregular rhythm. And so this is very indicative of atrial fibrillation, right? And so we have atrial fibrillation. So we have fibrillating waves through the atria, right? That explains why we don't have any good P waves. And the AV node is a bystander and is conducting the signal down into the ventricles. This patient also happens to have a right bundle branch block. So the right bundle branch is blocked, and so when the AV node does conduct the signal down, it conducts nice and fast through the left bundle to depolarize the left side of the heart very rapidly. But then we have slow cell-to-cell gap junction depolarization through the right ventricle, and that's why we get these late forces in the right ventricle, which is captured by this RSR prime in V1 and V2 that we see. So we have AFib that is conducted with a right bundle branch block throughout the ventricles. We know that we need to determine what the ventricular response is. We can see it's quite rapid. This is a 10-second strip, so we can actually count the number of QRSs. So I've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21. So this is 21 beats in 10 seconds. So if we multiply that by 6, we get 126 beats per minute is our average rate. And so this is AFib with a rapid ventricular response, which is any response in the ventricles that is greater than 100. So we've got AFib with RVR with a right bundle branch block. Let's measure our QRS axis one more time. We've got an upright QRS in lead 1. We've got an upright QRS in AVF. That tells me that my general axis of my QRS is down to the left, and so that's good and normal. Right bundle branch blocks don't often have axis deviation. So we have that. So we've, at this point, what have we done? We've looked at our atrial activity. We said we have AFib. We've looked at we didn't look at our PR interval because we can't have one, but we looked at, as a proxy, the response, right? This is our AV node. We looked at the ventricular response, which tells us how many times a minute my AV node is passing these fibrillatory waves down to the ventricles. We've looked at our QRS, our wide complex QRS. That's a right bundle branch block. And now let's look at our QT interval. And so sometimes you can just kind of eyeball and see, yeah, these QT intervals, you're going fast. If you would like, you can actually calculate the corrected QT interval, which is essentially dividing the QT interval. You can divide the QT interval by the square root of the R to R interval in seconds. That's how you correct for the rate. And so now we're going to look for any ischemic changes, right? Pathological Q waves and ST and T wave changes. Why is this person having a rapid ventricular response, right? Usually, we think of AFib with RVR as a physiologic response to some type of stressor. Are they septic? Are they having a myocardial infarction? Are they having a stroke? We need to determine what is the etiology. And so I don't see any ST or T wave abnormalities that are scary, right? We see some T wave inversions here, but I don't see any ST and T wave depression or elevations that concern me for a myocardial infarction. I would, though, compare this to a previous ECG because of the aberrant conduction. And so we can put this all together, and what do we get? Well, we have an atrial fibrillation with a rapid ventricular response. We have a wide complex rhythm that is consistent with a right bundle branch block morphology. So, hope this helps. AFib with aberrancy is common, and yeah, if you have any questions, throw them down into the comments. And if you have questions about the pathophysiology of AFib, feel free to ask. Love talking about it. So have a great day. We'll see you tomorrow.